In this lecture, we're going to be discussing cardiothoracic imaging, or primarily the chest x-ray. So we know in radiography we need differentiation of contrast to discriminate between structures here. So we need two views, usually a PA and a lateral view of the chest, to further evaluate and discriminate between the tissues in the chest. And radiography of the abdomen usually doesn't provide as much detail other than spine, pelvis, and gas in the bowels. So in those cases, we use a lot of contrast material, barium, those type of things to really look at being able to visualize these structures in the abdomen. So in chest radiography, it's the primary radiologic study that's used for looking at the heart, lungs, and all the lymph nodes and thoracic skeleton, and needs to be correlated with clinical symptoms. So it's quite often used to look at differences for lung function, breathing, diaphragm, and also looking at the heart. Other methods can often be used to further clarify, such as CT and MRI is needed for looking at function and anatomy, and ultrasound is very good for looking at the heart function. So our traditional views are a PA view, where you see here where the patient's standing in front of the x-ray film, and the x-ray beam is then directed from the posterior portion into the film. There can be a lateral view here as well. We have to have the arms overhead to clear the shoulder and upper extremity out of the way to better visualize the chest. Occasionally, portables are done for patients who aren't able to get out of bed or can be better assessed at bedside, and these are done with an AP view. So here's your normal PA radiograph. You can visualize a lot of different things here. You see the aortic knob, the heart shadow here. You can see some of the aorta and the right atriums over here. You see the diaphragm that functions here, and then you can see a lot of the ribs and their function over here. So you can get a pretty good view of what the chest looks like in this view here. And this is the female, so you can see a little bit more function here, functional stuff with the ribs, diaphragm, liver. You can see a gastric air bubble even in this case. And you got the soft tissue of the breast here that are visible in this. So being able to look at chest function here as well is important. So here's your key landmarks that we're going to be looking at. You need to be able to visualize the clavicles, spinous processes of the thoracic spine. You know the trachea is coming down the center of the spine in the upper thoracic area, and then it splits here into to the lung cavities. See the hilum, the posterior ribs. Cardiophrenic angle is around rib 10. The gastrophrenic angle down here, you see this filled in a lot with pneumonias and those type pathologies. You see the diaphragm, the liver here, the aortic knob is visualized there, and then the pulmonary arteries. So you can see a lot of different shadows here, primarily because there's a lot of air in these areas. So be able to think about these areas, things. The right atrium, left ventricle, right ventricle will be right in here. It's hard to differentiate because of the spine here. So just looking at cardiac anatomy is heart function compared to your aorta, your pulmonary vessels here. So those are always good to kind of look at and differentiate where these are in relation to the chest cavity. Your pulmonary anatomy, so you see the upper lobes here, lower lobes, And then you see a middle lobe over on the right and a lower lobe here. So you can see a lot of different fissures and things like that that are functioning here is with the lungs. And your lateral radiograph here, you see the right ventricle, left ventricle as it sits in front of the thoracic spine here. You can kind of see the shadow of the descending aorta here, and your aortic notch as it exits out here with the aorta. And then your pulmonary, you can see the upper and lower lobes here with the lungs here. Another thing you can do is use a CT scan or computed tomography. Being a digital x-ray technique, it does require a lot of radiation to the patient, but it does provide good differentiation of tissue densities and organs. So if you're really needing to look at specific organs, this is a good imaging modality to use. So here you can see a CT scan here of the superior vena cava, main pulmonary arteries, descending aorta, esophagus here, and the vein in front of the spine here. So you can kind of see different shadows here because the air is going to be very dark, and your organs then can be more of a gray shadow. So it's really a nice visualization of these tissues. So mainly the lung diseases we'll be looking at are pneumonia, atelectasis, pleural effusions, chronic obstructive lung diseases, the pneumothorax, pulmonary edema, and bronchial carcinomas. So if you look at pneumonia here, you see a lot of consolidation here in this part of the lung here. So all this is pretty thick, so it's not as a lot of moisture in here, so that's going to show up on the x-ray as what they call consolidation. So this is a middle lobe consolidation here. So this would be a right lung pneumonia. Here's a bilateral pneumonia. You can see here with the liver and a lot of consolidation in this middle lobe. And then if you look down here in this on the left, the lower lobe, there's a lot of consolidation here. There's not this differentiation of this angle here. So you see a lot of filling in of the fluid here. So this is indicative of what you would see with pneumonias. Atelectasis, basically just a loss of lung volume. So you see a lot of consolidation. You cannot find the cardiac border anymore. So you've lost a lot of lung volume here. So these are people that are going to have difficulty breathing. Then you got this pleural effusion. So you've loss of this cardiophrenic angle and loss of the diaphragm. You cannot see the diaphragm here at all. So this is a lot of filling in here of water content causing pneumonia. Then emphysema. So you see a lot of, don't see much of anything except for dark areas, indicating that this is more of a hyperexpansion of the lungs. See more AP diameter, pretty large space here as the lungs try to expand to get more air. So, and the diaphragm is fairly flat. So in the others you saw this big angle up and over of the this portion, and then the liver portion as well. Here it's very, very flat here. So these are all signs of emphysema. Then pneumothorax, there's just no lung markings here. You see different parts of the lungs over here. These bronchioles and everything here. You see a pretty flat black area here. You don't see much of a marking here, indicating that there's a lot of decreased lung volume. Plus you see this shift to the left here, or mediastal shift to the right because of this lung volume. Pulmonary edema, so you see just a lot of little kind of almost pellet looking areas here, a lot of infiltration with pulmonary edema filling in all these areas of the lung. I call this a butterfly distribution. You see the wings here and the butterfly. That's more of a pulmonary edema. And then you see the carcinomas here. You see a big mass right here, pretty solid looking, almost golf ball looking mass sitting in the lungs. So this would be a lung mass. Here you see the CT scan. You see this differentiation. You don't see these nice round borders. This has got a lot of projections off of it. So this is more of a carcinoma. So not a good history here for this patient. So if we look at cardiac conditions in the chest x-ray, you're going to look at your heart landmarks, your size. We can look at our CT scan, echocardiograms, radionuclide testing, and then angiography. So as we go back and look at our heart landmarks, you see the right atrium, right ventricle. There's your left atrium, left ventricle. You see your aorta. You see your pulmonary veins coming in. So you see a lot of different, remember your heart anatomy. So we're going to be looking primarily, what we'll see here is this, because of the spine, you'll see the atrium sitting out over here, maybe a little bit of ventricle. And then on this side of the spine, you see a good portion of this shadow of the cardiac silhouette. So I can look at the size of the heart within the chest, what they call a cardiothoracic ratio. So there's a description of it. So it's usually about 0.5 or half the diameter of the thoracic cavity. I say most radiologists are going to just eyeball this as opposed to directly measuring it. So here you see cardiothoracic ratio. So there's the C portion of it, cardiac portion of it. There's your thoracic measurement. So this should be about half. Whereas here you see an abnormal shift here. It's a little more than half here for this ratio. So that's an enlarged heart. And then you can look at the CT scans. So you can look at an axial portion as we go down a little bit lower in the chest cavity. You can see the atrium, the ventricles here. And then echocardiography here. So using kind of an ultrasound, high frequency ultrasound to evaluate your heart and great vessels here. So it gets you a good picture on the screen of cardiac anatomy and the motion of these structures, so they can really look at the valves and blood flow through the heart. So like I say, assessing the valves, ventricular function, looking for any type of disease. There are several different types of echocardiography that we're not going to really look at specifically, but there's ways to evaluate this with the echocardiogram. So there's you some views of what they'll be looking at, so I can actually see the function here on a short axis, lateral, anterior.